and the most awaited lecture and the panel discussion by the galaxy of Indian stars going to start soon. And the chairperson for that is Dr. T.S. Chandrasekhar, Dr. Ajay Kumar, and Dr. A.S. Puri. I request 1 minute, a small video, and after that I request chairperson to invite next speaker and then the panel discussion. Thank you.
At the outset, I will have a great pleasure and honor to be a part of this India-US meeting organized by Dr. Ranjit Sood and A.S. Puri, and the hero is Dr. Rajesh Puri. My congratulations for this wonderful, and congratulations to AAG for demonstrating very nicely the US guided GJ. 2 decades before, what was considered as a white elephant, now it has become a winning horse. And this is going to be a story to be told by Dr. Nageshwar Reddy, who needs no introduction, but I always have the pleasure of telling that everyone would like to emulate Dr. Nagi in many ways. And the latest achievement is the biggest gastroenterology hospital in the world, AIG. Nagi is the right person to talk about this. The reason is he doesn't do much US, so he'll be very unbiased. Number one. Number two is Nagi has seen the growth of US from 1989 onwards. I remember whenever there is a US lecture, just before the tea or just before the conclusion of the conference, all of them will be outside the hall. Now it is a totally different, and Rajesh Puri could conduct 3 days of US meeting. That is a sea change has happened. Kudos to the US team and our stalwarts who are really working hard. With this introduction, I hand over to Dr. Nagi, who is enjoying the tea, and he will bring more energy to all of us. Nagi, over to you.
Thank you. Can you hear me?
Yeah.
Thank you. Thanks a lot. I think TSC is very appropriate, as you said. It used to be black and white pictures that we are sort of neglecting, but now it's become a mainstream for us. So, in fact, I thought I was just strange that Rajesh asked me to talk on a subject that I'm normally not doing, but I think it's part of the growing up that shows that probably I'm getting to the retiring stage now. I have to give talks on things that I actually don't do also, but probably after 30 or 40 years of wisdom in this area of endoscopy, maybe I can share some of my thoughts on this area. So actually, Rajesh asked me to talk on when, why, and how, but I sort of modified it a little. And when, why, how, who, and which, all this I'll try and answer in the next 15 minutes. So my interest in US actually started in 1990 when I visited NIPS Ohendra unit, actually mainly for ERCP, but I was told in the side room there's another very interesting new modality that's coming. Amit was there with NIB at that time. ERCP, of course, was the purpose. We used to all go and see how it's being done. But I was told there's something very interesting whether you can go and watch there. So I went into the side room there, and I saw that they were doing at that time just starting endoscopic ultrasound. The room was very dark. The machine was very heavy. In fact, the person who was doing this seemed to have developed periarthritis. The screen was very grainy, and the doctor who was actually doing it was Dr. Grimm. So adding to all this, I realized that endoscopic ultrasound is not something very attractive. So when I came back from the unit, I was actually sort of forced into buying an endoscopic ultrasound machine in early 90s, 92, 93, we got the first machine. Uh, and then started using this because Olympus sort of told me that this is going to be the new thing. So I started doing it. In fact, I did US for 1 year and found at that time that it didn't add too much to my clinical practice because it was very, very early, rudimentary. The pictures are not very clear. And we are used to so much of color pictures, are suddenly black and white. In fact, I spent some time with an ultrasonologist who was very good to understand anatomy. Uh, the at that time, US was predominantly being used for esophageal lesions to look at the mediastinal nodes and so on. Pancreaticobiliary US was not so much into vogue, and endoscopic FNA just started. US FNA just started, so it was something which was not very attractive. I gave it up, and subsequently, one of my colleagues, Dr. Sriram, took it up, and I could see that over a period of time, it dramatically improved. And of course, you now know that endoscopic ultrasound has become extremely important. And look at what has changed. Not only has the room, which is dark, pictures which are very grim, have been replaced by modern endoscopy. This is our US theater, one of our US theater. And you can see that not only that it looks very bright, but you also have a camera right there. One of the few luxuries an endoscopist can have is a camera. This is actually a remote camera. They take US FNAs, put them on, and the pathologist from the pathology room can actually read, put it up on the screen, tell us what we are seeing, so that you have rows, which is done by even a distant pathologist. So I think there's been dramatic improvement in all ways in the US, and therefore I think US has become a very important part of GI endoscopy, so important that it can't be separated from a routine endoscopy practice. So let me start with the first rider that endoscopic ultrasound is now, unlike what it was in the past, a very important part of GI endoscopy. We started initially with diagnostic FNA. As I was telling you about, it used to be predominantly esophagus, and now nobody does esophageal US anymore. It doesn't have very little value it's got in terms of how we are going to map the nodes and so on. FNA came from there, but then FNA soon went into FNB, which is predominantly pancreaticobiliary now. And most of our therapeutic work, as you can see here, is concentrated on pancreaticobiliary. In fact, to an extent that we are now becoming further into this field, like endoscopic ultrasound guided gastrojejunostomy. We're creating a lot of anastomosis. And of course, there's a radical thinking now among some of the endosonologists, which of course I try and oppose, is that even primary ERCP should be replaced with EUS drainage of the pancreaticobiliary tree. That is, you don't attempt ERCP at all because they believe that less pancreatitis can occur if you do it through the biliary route. Of course, still disputed, but I think this just shows how far we are going. The horizons of US are dramatically expanding, and one of the regrets that I have in my life is that I didn't take it up very strongly at that period of time because it didn't seem to progress. But two of the icons in the field of pancreaticobiliary endoscopy, Jack and Rob, you can see here, went very early into this, and of course now have become pioneers. And I believe strongly now, retrospectively, that if you are want to be a good pancreatic or biliary endoscopist, you have to be also, in addition to a good ERCPist, a good endosonologist dealing with this area. I think TSC would agree with me because he also took up very early. Probably I'll have to put one of his pictures sometime here also. So you see, I think this is now, I think the term pancreaticobiliary endoscopy constitutes both EUS and ERCP, and both cannot be separated. So for all young gastroenterologists who are going to take up a pancreaticobiliary endoscopy with passion, you must learn, do, and become an expert with endoscopic ultrasound. So this is the first point that I'd like to make. So who should take it up? Of course, anybody who wants to do pancreaticobiliary endoscopy should do US, but there's a problem here. The problem is, I think those of who are listening to this lecture, the youngsters especially, have to now say they belong to which group. Who are they? Are they doing solo practice? Are they doing group practice? Are they in corporate hospital? Or are they in this semi-autonomous hospital where they can do practice and also do their clinical work? So first of all, you have to sort of now think over and classify yourself into which group you belong. I'm not getting government here because some governments allow practice, some don't. But we predominantly, I was asked by Rajesh to talk on private practice, who and how to set it up. So put yourself into one of these groups, right? So before we go further, I just wanted to look at the economics of US. One of the things I'm very bad is economics of anything. So what I did is I asked my CFO to look at this very carefully, and some of the data that I'm presenting here are something that you may like to sort of actually take pictures of, because this is they've done some very good study, deep study into this and came up with this. So average cost of a linear US, and I'm saying linear because that's what we use now predominantly, costs about 1 crore rupees. I mean, you can bargain with go for cheaper models, but this is the average. Now, the average cost of endoscopic ultrasound diagnostic in our institute is 8,000, but can go up to 15,000. This is a variable that I put. And 70% of cases of our endoscopic ultrasound are falling into this category of diagnostic ultrasound. This is in most centers. I've taken average in most centers. The average cost of FNB, which is the next most commonly done procedures, 22% of the cases, is ranging between 25 to 35, again, depending on the institution. The FNB needles are costly. They cost 20,000. We reuse them. So therefore, you can cut down the cost. Otherwise, you'll have to charge higher for the patients. And of course, next predominant common procedure that we do in our patients is stenting, which ranges again from plastic to metal stents, costing between 30 to 1 lakh. The average income you generate from these put here 5,000 from a diagnostic ultrasound, 6,000 from FNA, and 10,000 from stenting. Again, these are very averages, can vary depending upon where you're practicing, which institute you're practicing. Now, how does this economics work? So if you actually look at all the procedures, I'm not talking about individual diagnostic procedures. So if you take all the procedures done in your unit, per procedure revenue for an endoscopic ultrasound is about 23,000. Of these consumables, contribution in terms of salaries to your staff and other people, manpower, lower manpower costs, and overheads, which is either the annual maintenance contract or the CMC, which is a comprehensive maintenance contract, would come to say for 4,000, which is, this is all percentage of how much each takes up to. So if you take up this, actually the per EBITDA cost, this is actually earning before tax and depreciation, is about 5,000. This is the terms that they all use in corporate now, is about 5,000 rupees per procedure. So whether you're doing a diagnostic ERCP or doing a therapeutic ERCP, on average, if you take out all these maintenance costs, manpower, contribution, and so on, is about 5,000 rupees per scopy. So to break even per year, you'll have to do almost 2,000 procedures, 2,000 procedures per year to break even for a single endoscopic ultrasound scan. This is statistics from our team. You can see that one, we have very large team. We have a large number of scopes. So when in a good year like 2019, we did almost 6,000 cases a year. We dropped down in the COVID era, but again picking up, which means that even in our unit, which is extremely large volume unit, one of the largest volume units in the world, we have about 5 scopes. So we are not even breaking even. I also looked at the various data that we got from different institutions in our country. The average of number of US that are being done in larger corporate hospitals, the highest 10 ones, are ranging from 700 to 1,500 cases a year, which means that even in these cases, you're not going to break even. Now, why I'm emphasizing this before I come back to who should be doing, whether it's all interventional gastroenterologists, come to this scheme that I told you should put yourself into this group and just look at the economics that I just presented to you. And look at the economics I presented to you, just based on, this is again very important. You realize that you are very passionate, you want to do it, patient care improves, but you have to look at the practical aspect. For a solo practitioner, I think taking up US is not going to be very useful if you have a single person practicing in your small place, unless you're making so much money in rest of the practice, you don't mind putting it into US and you don't make up that money. Or if you have a very rich father-in-law, this is of course another indication if you can buy a US. Otherwise, for groups, corporates and semi-autonomous, you can go ahead and buy this US, because in this area, either in group or corporate or other hospitals, what happens is part of the thing is shared by other scopes and so on. I'll come to that a little later. So I think, so the first question of who should buy and set up an endoscopic ultrasound would be that those who are in group practices, those who are in corporates, those who are in semi-autonomous institute, not solo practitioners. For solo practitioners, I'll ask you to be very careful before you go for this because of the economics involved. So, but why should you set it up? Again, those in groups and the corporate should not think of economics there, because economics in US will not work out. Economics work out with endoscopy, colonoscopy, but not US. But you should do it because one, of course, you dramatically improve your patient care. There are many instances like gallstone pancreatitis. We would never do an ERCP now without first doing endoscopic ultrasound to demonstrate a stone. The whole practice has changed. We have wound drainages, so many other indications. So patient care will definitely improve. The image of your hospital, the institute, the center where you're practicing would again improve, because if you have an image, if you have an EUS, you then go into a different category of practitioner compared to those who don't have any. This is also used as a marketing device, of course, that I think I don't have to tell most of the seasoned practitioners here, that this is good to say that you have this in your unit. And of course, the most important thing I think is the doctor satisfaction. If somebody had to ask me, can you tell me one reason why young upcoming endoscopy should go for US? I'd say the satisfaction you get from the patient care. It's a complete patient care. And sometimes you can make dramatic differences in terms of how these patients are algorithmized or treated. So we then come to this question of when should we do it? Should we do it? So you pass your DM or DNB, should you immediately go for this, or should you wait in the some part or do it at a later part? So again, there are several differences or several thinkings in this area that I just like to discuss on. My opinion is that if you're going for endoscopic ultrasound, you should go very early. The first thing you should decide in your career is, again, this is basically for the young endoscopists, is whether you want to go very aggressively into endoscopy. If you want to go very aggressively into endoscopy and not hepatology or functional bowel disease, if you want endoscopy as your primary modality of practice, then you should go in very early, because all pancreaticobiliary endoscopy should also know US well. Of course, later you can subdivide into third space endoscopies and so on, but I think all passionate endoscopy should go very early into there. So you may not have this opportunity for everybody, but if you're thinking of this, then what I would suggest is you join a group where already US is present, or where the group or the corporate hospital has a capacity to start endoscopic ultrasound. So this is important. But sometimes what happens is, say 10 years after practice or 10 years after being in a place, you realize that this is becoming important. So then, of course, middle part of your career, you'd want to get into this. This is also okay in middle part also, because some things, for example, like drainage of wands and so on can be done very easily. You don't have to be an expert. And if you're in a setup where nobody else is there to do this, it may be worthwhile even to go to some place, get trained in this particular procedure and come back and set it up. There are rare instances where much later part of your career, say after 20 or 30 years of practice, you want to start it. And even that, I think, is a small exception where endoscopic ultrasound skills can be very easily taken up. If you're a good endoscopist, it doesn't take much effort. You just have to know the anatomy to take it up and then start practicing it. So these are the three stages. But my opinion is that you should start very early, immediately after you finish your early endoscopy, advanced endoscopy training. One of this should be to take up US. Now, the other question is which? In my opinion, of course, we have radial and linear. When we started the US, everybody used to start with radial, then go to linear. And in fact, I was discussing with my colleague Sandeep the other day, and he said, no, always radial I'm very comfortable with. But this has changed now. We no longer use radial. It's all linear, linear, linear. So don't get trained in radial at all. Don't go for radial at all. Don't buy an extra scope and waste your money. If you are going to go for US training, you must go for linear directly, because linear scope is the one which is we use for everything. And most of the US has now graduated from being diagnostic to therapeutic, and all the so-called diagnostic are also FNAs and so on, FNBs. So therefore, there's no point in a radial. So go for a linear scope and get trained in a linear scope. And having one scope, of course, will save you from investing too much into other scopes. But what about training? This is again very, very important. So let me spend some little time on this. Again, in the earlier days, we didn't have much facilities for training. It used to be one-to-one. You go to a place where this is being done, like I thought, let me see what happens in Sohendra's unit. And then, but what happens with one-to-one training is difficult now because of the large number of people who are coming up. And to train one-to-one for trainees is difficult. So again, this is something which is very unpopular with the trainees, that I've keep saying that during your course, 3-year course, either DNB or DM and so on, one should not aspire to start thinking of training in US. You can see your seniors doing it. You can see what are the indications. You can get an appreciation of the whole process and anatomy. But to train just for this, I don't think is a good thing. In fact, I think one should reserve this training on US to post DM, where you are going to do 1 or 2 years of specialized training in this area. Or you join as a junior consultant in some place which is already doing a lot of years. For example, many of the consultants who join here in our unit as junior consultants keep their extra time and watch how US is being done by seniors like Sandeep or Rakesh or Rajesh and so on, and then pick up from them. This is one of the way to pick up one-to-one. But if you have an opportunity, simulators are also not bad. In fact, there are, compared to endoscopy, colonoscopy, or ERCP, in my opinion, simulators are much superior for US to learn from, because they're fairly good in terms of anatomy and so on. And there's some simulators which, for example, Olympus has got, where you can actually learn very well on this. And we have now started doing biosimulators. You take a stomach from a porcine model, and then you can actually make a pseudocyst-like or Vaughan-like thing, and then start your training on this, how you can puncture and so on. So it becomes not so bad. Visiting centers is very important. And this is, again, I'd recommend that there are hardly, say, 10 centers in the country doing a lot of US work. You can go spend 2 or 3 days to see what's happening, because in every center, the approach is a little different. The expertise is in some areas. So I would suggest for the youngsters, again, before you start full scale, just go and keep visiting centers, doing what's going on, happening. And if an opportunity to go abroad and visit some of the centers to see, observe what's happening. But I think predominantly what has happened in, I think in India, and this is a good sign, is that the workshops, a lot of these workshops have hands-on training centers. Like the training center, whenever we have a training on US, we find there's a huge amount of rush. A lot of people want to come and do. I think this is good, because you get a fairly realistic hands-on experience on the porcine models that we have now. And things like puncture, FNBs, things like drainage of wands and all can be, you can get a fairly good experience with this type of workshop. So if you're interested, you must attend these workshops. I know that because of COVID, these have stopped now. They'll start soon again. And I think meetings like what Rajesh Puri is sort of organized like this are also going to be extremely important, because you can actually get close to what's happening. And the other important thing is, again, this is for the junior consultant. If you don't have many people around you, if you're starting in a small group, or if you're rich enough to buy in a solo practice and start this, what I would suggest is you invite some senior consultant to come to your place once in a month or once in 2 months, pile up your cases and let him start doing, and under the guidance you start doing. This is an easy way of learning, a fast way of learning the procedures. And of course, there are many, many symposia, as I told you. You should start attending this. In fact, we're fortunate to have this in India sometime back, where again, hands-on training becomes very important. Keep attending this hands-on training and keep attending this. So in conclusion of who, why, when, and which, I would suggest that EUS is a serious business. Don't go half-hearted into this like what I did in the beginning of my career. Take it very serious. If you are a therapeutic endoscopist, you should learn, be good at EUS, be passionate, because it's a part of pancreaticobiliary endoscopy. Unless you decide very early on that you won't do pancreaticobiliary, you will only do third space, which would be very unusual in the circumstances in India. I would suggest that all passionate endoscopy should go into US. They should start early in their career, not later on, because that's the best way. And the hands-eye coordination is the best at that time. Kindly look at the economic angle. I mean, I'm not saying that you should make something out of US, but I think it's very important to integrate the US economics into the rest of your endoscopy economics, as I showed you before. I think you should be reasonable, so that at least if you're not, you'll definitely lose money with the US, but at least it should not be dramatic, so the rest of the endoscopy group comes down completely. Join a group. Very, very important, not only for US, for everything else in endoscopy. I think you should join a group, because the group makes a difference. And in a group, not only you learn faster, but you learn from others' mistakes. Also, your mistakes are covered up by others. So already where endoscopic ultrasound is being done, really join that, and you can very rapidly learn and become a master in the technique. Because mastering the technique in US is very important. And believe me, I'm having observed this for a long period of time, having attended thousands of workshops. What I can say is that EUS is much easier to master than either ERCP or third space endoscopy. It's very, very easy, because it's a very anatomy based technique. The technical aspects are very less. It's more anatomy, and it's very easy to master. So I think this is just my advice to most of the youngsters who are trying to learn this. And again, as I said, join a group practice, enjoy your technique, and enjoy the training that comes with it. Thank you very much.
Thanks, Nagi, for a wonderful talk. Can we stop the screen sharing? And Rajesh, can you tell us, is there any time for question answers on this lecture, or
I think we can shift to the, because this is a shift to the panel discussion, so we can remain on time.
Okay, just let me say, see what it started like. I mean, the lecture is actually words of wisdom. I mean, to simplify in such a nice manner, it just does not realize that how much of experience behind this, and which the right words will be the wisdom of 30, 35 years of practice has been put into 15 minutes of talk, which is acting useful for each and every one of us. Nagi focused it on the beginners. I think it is actually relevant to all of us at whatever stage of our career we are. Thanks, Nagi, again for being a leader and for being giving an enlightening talk. And I'm sure that all audience would have enjoyed it. With that, we will pass it on to the panel discussion.
Yes. Thank you, Ajay. Thank you.
At the outset, let me customarily thank Dr. Puri for inviting me to moderate this session. I am privileged to have two eminent chairpersons here, Dr. T.S. Chandrasekhar, one of the most eminent endoscopists in the country and in the world, and Dr. A.S. Puri, a great gastroenterologist of this country and in the world. I'm very fortunate to have 5 people in this panel who have actually started becoming famous as endoscopists and gastroenterologists before endoscopic ultrasound came in. Correct me if I'm wrong, but Nagi onwards, they have been stalwarts in gastroenterology for about 35 years. If you want to claim greater number of years, please don't do so. It will make you sound very vintage. Okay, so stick to what I am telling you. I know all of you personally. Randhir Sood has been my colleague and a year senior. Amit Mahadev, a great doyen. Mahesh Goenka, brilliant gastroenterologist from PGI Chandigarh and the great star of the East. And Adarsh Chaudhary, the most preeminent gastroenterologist, the GI surgeon who is right now in Medanta. It's a privilege to have all 5 of you. And I've personally requested all of you to talk from your personal experience rather than quote literature for this particular panel discussion, because I want people to actually get a feel of what it is like. And Nagi, I must tell you, I was very impressed with your previous talk. It was extremely practical, pragmatic, and I would say very sensible to people like me who are young. Okay, so let me start. Let me start with our panel discussion of endoscopic ultrasound. The first round is on diagnostic, and the second round is on intervention. So the first round, we'll keep it very simple. So I have tried to break it up into different regions. So when I say regions, I'm not talking about Delhi and Andhra Pradesh. I'm talking about regions of the GI tract. Okay. So if that be so, let me start with Dr. Randhir Sood, the great biliary pancreatologist, the gastroenterologist and endoscopist. I've admired him ever since my resident days. Randhir, which is the area of biliary, shall we say, gastroenterology that you do? You're a preeminent therapeutic endoscopist, where you now feel that this endoscopic ultrasound has become a reluctant must for you. You are a great guy even before endoscopic ultrasound came. So let me remind you, it was 1990 when endoscopic ultrasound came. It came into India roughly around 96, 97. So it came to your hands around that time. But the fact of the matter is, all of us were rather reluctant about what's the future of this procedure. And now it has become a tremendously impactful procedure for all of us. So where do you use it for your diagnostic biliary work, where you think that you would call in a endosonographer to kind of tell you how to go about it?
I think there are very important three areas. One is the stones in the bile duct. When in doubt, like Nagi mentioned in his lecture, that if you are going to go in for ERCP in a patient of biliary pancreatitis, and you have to do an endoscopic ultrasound or MRCP, and we prefer to do an endoscopic ultrasound if patient's breathing is not a problem, because then it's a single sedation and you can do both the procedures. Second area is distal CVD stricture, and without with or without mass, because that's an area which can be appropriately investigated and biopsied, histology or cytology proof attained by doing an endoscopic ultrasound. Third is, of course, the pancreas, particularly when we are talking of pancreatic cystic masses, where endoscopic ultrasound definitely is of importance, not in diagnosis, because it adds to not only morphological evidence, but also fluid analysis from the cyst. So these are basically, I'll say, three areas apart from the previously used area of microlithiasis for recurrent pancreatitis and early chronic pancreatitis, which I think are not as useful today as over the period of time we have realized their fallacies.
Very good, very profound and to the point. Thanks a lot, Randhir. We move to Nagi. Nagi, you have been working on pancreatic disorders for a very long time, and your expertise is well known. So which is the kind of pancreatic disease where you think, not in terms of building up your numbers, in AIG, but where you really think it has a role to play, that you would want Sandeep to come in and kind of assist you in a decision making that you normally resort to?
Yeah. So I think very important is that US has moved from the upper segment into the pancreatic biliary area now. And Randhir rightly told you those three areas. And even in the pancreas, of course, gallstone pancreatitis, pancreatic cyst, we know, but area where we predominantly use it a lot is regarding when there's a pancreatic mass. When there's a pancreatic mass, you want to know the nature of the mass. FNB, we are again moved away from FNA now. We no longer do FNA, we do FNBs only for a variety of reasons, including the need to get a tissue as a whole, for example, autoimmune pancreatitis and so on. Where it has been disappointing also is that staging. In fact, when you have a pancreatic head mass, sometimes surgeons say, can you stage it to the US? But there it's very disappointing. I think there a good CT is better than US. So predominantly in the pancreatic area, I would suggest that if you have pancreatic mass, especially head masses, looking at these masses and an FNB would be extremely useful, not very useful for staging. So I think, again, this is a message that should go to youngsters. Although if you look at the textbooks, normally they say that venous lesions are better seen on US and arterial lesions better with CT. I think that with the current CTs, very high-end CTs that we have now, for staging, we generally use CT, but for the mass itself, to get a histological diagnosis, very often we use US.
Yeah, can I provoke you, Nagi? So, like a lot of people come with recurrent pancreatitis, and, then we are called upon to pronounce whether it's early chronic or whether it's acute relapsing, if at all you believe in that old Marcellus classification. Where do you think US fares there, and how reliable do you think it is?
Yeah. So again, this is something we published on where we looked at a large series of acute recurrent acute pancreatitis. Because if you look at all the algorithms, they'll say that after ultrasound, you go to acute recurrent, you go to endoscopic ultrasound in these cases. The yield, however, is very low in these cases. Because one, of course, MRCP covers many of these things. There are very small percentage of cases which EUS gives additional information. For example, an undiagnosed CBD stone which is not picked up, less than 6 millimeters, sometimes you don't pick it up on MRCP or ultrasound, or choledococele, which can sometimes be predominantly picked up by EUS. Sometimes worm infestation, which again, sometimes you can, like for example, even ascariasis, which can be picked up or has been missed by other condition, and the small cysts in the pancreatic head region, like branch chain cysts, which are also responsible for recurrent pancreatitis. So it's actually a very small percentage. And in that study, we showed that addition of EUS actually adds only about 10% in your diagnostic algorithm.
So not too much of a help in
Yes.
that situation.
Although we do
Great.
it routinely, I would not say that we should not do it as a routine algorithm we do, but if you go into actual practice, the pickup rates are not very high.
It doesn't change your
And the other
outlook
thing
too
I
much.
want to emphasize here, GC, is that this concept of chronic pancreatitis, people say that when you do an EUS, you convert RAP, recurrent acute pancreatitis, into chronic pancreatitis because you're picking up some one of the Chicago classification, Rosemont classification.
5 out of 7 types.
Yeah, which I think again, I think people is something that at this stage of life you're not taking very seriously. So I
Very
wouldn't
good.
really-
I'm so happy that you have
concept of chronic
become a very mature, wise person. Very good. Because I keep hearing about 3 out of 7
Yeah.
factors and 4 out of 7 and so on and so forth. But nevertheless, we could have controversies on that. Today, I think the audience is a lot of young aspirant endosonographers.
So if you have a recurrent pancreatitis chap who's bugging you all the time, then best is to get to you say, okay, look, you have chronic, not recurrent acute. So everybody is happy. He's happy, you're happy, family is happy.
Wonderful. Now I come to Dr. Amit Mahadev. I think everybody knows Amit as one of the leading endoscopists of the country, trained at by Dr. Sib Nib Sohendra, and right now in Bombay for a long time, and he's one of the preeminent endoscopists of the country. Amit, how do you fare, or how do you assess endoscopic ultrasound as a modality for cancer staging, especially of the biliary tract and the pancreas? There are so many forms of staging. We have been resorting to CCT, PET CT, MRI, and now endosono. So where exactly do you use it?
Well, actually, I feel, as others said before, that nowadays we rely more on CT scan, a good CT scan for cancer staging, as far as the HP malignancies is concerned. But there are a few areas where maybe EUS will be a little bit better, give better information. One is if your diagnosis and staging. Now, diagnosis, sometimes we find on various imaging modalities, we are having a thickened gallbladder. Now we want to rule out whether there's a gallbladder malignancy or whether there's something inside the gallbladder. Now, with EUS, we get a very close view of the gallbladder. And with that, we can pick up such type of a malignancy of the gallbladder more accurately than a CT scan. Second is lower bile duct. Lower bile duct areas where sometimes CT scan is not giving us a proper diagnosis, where EUS, where we are going very close to the lower bile duct, where we can get even a thickened lower bile duct. A proper diagnosis can be done with a EUS guided FNAC of the bile duct, even if your breast cytology is negative. And pancreatic malignancies, there's some noise coming from pancreatic malignancies. For example, CT is better. See, because only EUS, if you are grossly seeing that there is a portal vein infiltration or a confluence infiltration or a SMA infiltration, which is not commonly seen, SMV we can usually see on EUS, then we can clear cut say that this is inoperable. So loco-regional operability that gives us, but CT is better. Another very important area is ampullary tumors. See, whenever we are going to do an ampullary resection for ampullary tumor, EUS is, I think, mandatory, because EUS gives us the most accurate way to tell us how much the tumor is infiltrated inside the bile duct. And that will tell you whether it is suitable for endoscopic resection or a surgical resection. So if you ask me, these are the 3-4 areas where we rely on US. Otherwise, I think CT is now the prime imaging modality for staging of HPV malignancies.
Wonderful. So let me reiterate. I think Randhir Sood made the point about lower CBD, which has been reinforced by Dr. Amit Mahadev. So the lower CBD thickening or the doubtful area, I think Endosono seems to be very useful. So there is a lot of concurrence on that. I must admire the maturity of the 3 panelists up till now who have said that, initially when Endosono came, it looked like this is the the new chip on the block. I mean, in the sense that this is revolutionizing everything. But they've gone back to saying that, look, CT also has a role to play in staging. Endosono can be a little complementary in loco-regional staging rather than actually replace it. So I think our conventional modality still remains. And I think Dr. Mahadev has very rightly talked about pancreatic malignancy loco-regional staging, which I think everybody would agree with. I now move to Dr. Mahesh Goenka, the star, what do you call it? The Magi called it the star, so he's the star of the East. So Mahesh Goenka, the question is fairly easy for you. So, when it came in, Endosono, I remember that time I was in training in Japan and I came back, that was 1991. The main area of Endosono was actually in loco-regional staging of GI malignancies, especially esophagus and stomach. But I want to throw it open in a big way to you. In your practice today, which are the kind of lesions where you use it for luminal submucosal lesions or luminal tumors or wherever you have in terms of staging, and how it impacts your practice?
Thank you, Dr. Gurdas Chaudhary. And before I answer, I'll take 30 seconds extra to talk a little beyond what your question. First, I must compliment for choosing the right moderator. I think Gurdas Chaudhary, people may not remember, was the first person possibly who started US when he was in the SGPGI. I remember when I was doing my DM, we came to know that there's something called US started in SGPGI. So I think Rajesh and Randhir has chosen the right person. Second, about the economics, which Dr. Nagi talked about, I have a little different talk about it. And I would say that when you do a liver transplant, you really do not earn from a liver transplant. But because of a liver transplant, you have hundreds of patients who are being investigated, who is worked up. And so the economics goes beyond one liver transplant. That's what I look at from the CFO's perspective, Nagi. About the answer to that question, a couple of the panelists were trained by Mrs. Nagi as a radiologist. I think Nageshwari will remember, TSC would remember. And she would tell us how to differentiate an extramural lesion from a submucosal lesion, looking at the angle between the lesion and the wall. I think those were presumptions we were going through. And so I think that answering straight to your question, I think the main reason which I find is evaluating a bulge or a submucosal tumor, and to find out whether the bulge is first, whether it's intramural or extramural. And then looking at the location, the layer from which it's arising, the echogenicity, we can possibly, even without a biopsy or FNA, say whether it's a lipoma or whether it's a GIST or whether it's a leiomyoma or a carcinoid, a granular cell tumor. So I think that's one big thing. And then, of course, you can do an FNA, at least in majority of these cases, and you're required to do them when the lesion is more than 2 centimeters in size, except in lipomas, which are so characteristic, and to avoid duplication cyst. And then you do a biopsy of these lesions and actually tell what you're dealing with. So that's one component. Second is extramural. I think the lymph node. For example, in the mediastinum, we can visualize the lymph node. We can analyze again, look at the pattern of enlargement, whether it's benign, malignant, then do a tissue diagnosis, find out some of the features for a lesion like tuberculosis, which is so characteristic. You may find necrotic areas in the center of that and find out whether it's a tubercular lymph node. So that's the second one. We've already talked about loco-regional spread, so I won't dwell on it. But there may be surprises of a distant metastasis, like a left adrenal metastasis, or a celiac node metastasis, or a left lobe liver metastasis, or a chink of ascites, which may be present, which may alter our approach to a particular case. So I think, to summarize, visualization of these areas which are suspected and then biopsying them. Biopsy can be for submucosal tumor. Biopsy may be for staging, particularly in the esophagus. And the biopsy can be a diffuse mucosal thickening or a wall thickening sometime, where you can do a biopsy based on EUS. I will only say the last point that in the rectum, gradually the importance of EUS is coming down with more and more high Tressler MRIs and CT scan. Whereas in esophagus and stomach, I think EUS plays still a major role. So that's my summary.
Thank you so much. I think that was extremely profound and very concise. I think we are running out of time, so I'll be a little brief. But Dr. Adarsh Chaudhary, you are the person who finally delivers. Like we keep discussing and debating that whether it's resectable or not, whether it's a tumor or not. The call is yours. You have to really open up this fellow. And if something goes completely wrong, then, you have to answer. How often do you find it essential to rely on an endoscopic ultrasound finding before you decide that I'm going to open up this guy and try and attempt a resection?
We rarely use an endoscopic ultrasound for our surgical decisions. In hardly any esophagogastric cancer, rectal cancer, pancreatic cancer, gallbladder cancer, EUS is not a determinant for surgical intervention. We might use it to get a fine needle biopsy in a locally advanced pancreatic cancer. But these days, with the CT scan and PET scan, we rarely need to do an endoscopic ultrasound for taking a surgical decision. And to me, it appears that in such cases, the picture is more clearer than the plot is. So I think we really don't need to do it. If you have it, you want to force it on us, it's okay. But for surgery, we don't need an endoscopic ultrasound for staging.
Have you had a fight with Rajesh Puri yesterday or something?
No. Rajesh Puri is a very objective guy. You talked of cancer. There are benign diseases where it has a great role, but for cancer, I don't think it has any role, at least for surgeons. You want to do
I'll tell you, when I was doing my endoscopic ultrasound in Japan and I came back to India, there was this paper which appeared in Gastroenterology with the first author, Paul Fokens. And the article was on staging of esophageal cancer by endoscopic ultrasound, 60 patients. It was in Gastroenterology. And after that, I had the privilege of inviting Paul Fokens to SGPGI Lucknow for a one-day workshop. So that time, the whole issue was that, it can actually improve your staging by 30% over what CT was doing. So I just wanted to kind of revisit, I'm a vintage guy now. So I just want to know that, at the moment, we have receded back to CT, have we?
Absolutely. Gurdas, you're such a learned man. There's a fact in science which is called as mesofacts. Mesofacts are facts which keep changing. So we need to understand.
It's something like fake news.
No, it's not fake news. Fake is fake. Meso is changing. So in 1980s, it was relevant. Today, with high quality CT scans, I think it's a waste of money, time, and energy to get an endoscopic ultrasound for diagnosis and staging.
Great. So, Adarsh, as usual, you have been very forthright and objective and crisp as ever. I've been seeing you from the days of Gaya, which was way back in, I think, in 91 or 92. So, very good for your very crisp messages. When I go to round 2, I'll probably take very little time, but I can see Amrinder Puri and Dr. T.S. Chandrasekhar waiting to comment. If any of you have any comments to offer, please come in. Amrinder, anything you want to add, or TSC?
Yeah, I want to make a point on, I think we've covered a lot on malignancies, the diagnostic, staging, etc. Am I audible, sir?
Yes, please.
Yes.
Oh, so I have more than a passing interest in GI infectious disease. And one of the areas where EUS is, I think, the investigation of choice is in disseminated histoplasmosis. Now, because of this EUS, the adrenal, especially the left adrenal, is become so accessible that this is, I would think, if I was to make an algorithm, then I would put, whenever you are suspecting histoplasmosis, the first investigation to be done is, and my friend, Dr. Rajesh, we are colleagues in the same department. So I always turn to him, and whenever we are suspecting, and sure enough, he obliges us. And we've had excellent results when it comes to this. And the second point that I want to make, this was with regards to infectious disease, and not entirely nothing GI about adrenal, but when you are in the business, then you cannot say this goes to somebody else. And the other area which I think is likely to come up in the limelight in the future, this is almost I'm reluctant to make a prediction, but in Europe and also in Australia, IBD, especially ulcerative colitis and Crohn's disease, is being assessed by ultrasound, percutaneous ultrasound. And it is possible now, the next area is going to be whether measuring the focal wall thickness through EUS is likely to be play some role, because they're saying depending on the thickness of the bowel wall, the thicker your bowel wall is, the less likely you're going to respond to medical therapy. So maybe this is another area that is emerging.
Great, wonderful. Amrinder, let me tell you, in your previous avatar, before you joined Medanta, I think you were the chief and head of GV Pant gastroenterology, and I think the person who was doing endosono there was Siddharth, if I'm not mistaken.
That's right. So this Siddharth was.
So in my second avatar here in Fortis, I had a very difficult patient from UP, and who had a left adrenal swelling and had high fever. Fever going on for a year. And I had sent it to Siddharth, and he did an endosono guided FNA, and it turned out to be histoplasma. And he was treated for a year. He did extremely well. And in fact, he has been alive for the last 4 to 5 years. So I would just want to reiterate that point that you made, that adrenal histoplasmosis and, getting an access through endoscopic ultrasound, I have actually verified it in my own practice. Wonderful point. TSC, I'm sure you're itching to make a point. Go ahead.
No. Only thing is...
oh, come on, yaar. Very happy Pongal to you.
Only thing I'm just seeing others after a long time, but he has not changed in his views about the physicians and the gastroenterologists.
That's what happens to vintage people like Adarsh and me. So let's go on with the next one. So it's okay, yaar. We believe
others, when you have a malignancy in pancreas or benign, you don't even go for the biopsy, endogated.
We will only do a...
Or you like to go for CT or...
Don't force others to change his views yet.
No. TSC,
I think TSC can never do that. TSC won't be able to do it.
TSC, we only do a biopsy like you taught us many years back, that when they're only borderline resectable or locally advanced. Resectable lesions, you have taught us that they don't need a biopsy. We learned from you.
Adarsh, I admire your diplomacy. Shall we go to round 2? So we are now going
my
to
guru.
intervention.
This is my medical and non-medical aspects. Is my guru.
Yeah, very good. So we are going to round 2. We'll be very quick because we are running out of time, and Rajesh Puri is going to ring the bell. So first one to Dr. Randhir Sood. Randhir, we talked about diagnostics, and you mentioned a little bit about, the CVD stones which have not been picked up by an MRCP and so on. Where exactly do you find endosono guided punctures and putting in needles and therapeutics useful in the biliary tract? I know you're a great guy with the biliary tract. No, we can't hear you. Randhir, I think you're muted. Sorry.
Today we are predominantly using it for malignant biliary obstruction when it is not accessible to ERCP, and we can do a hepaticogastrostomy, duodenostomy, or if in a failed ERCP, if we want an access to the bile duct, then that's the second situation where I would use it.
Oh, great. Do you use it for anything else in the gallbladder and anything else?
Well,
or is it...
gallbladder, we just, yesterday did a case of cholecystogastrostomy in a patient of empyema or a patient who is too sick for any surgical intervention but needs a drainage. So we prefer it to the percutaneous drainage because that has significant morbidity to the patient.
Well, I think you're very lucky to have a wonderful colleague as Rajesh Puri to be able to, give such accurate results, both diagnostic and therapeutics. Rajesh,
Absolutely.
Congratulations. You've become one of the great pillars of endoscopic ultrasound in the country. I'm so proud of you. Can I move to the next person, Dr. Nagi? Nagi, it's a little, a question which is a little off the usual. because I know that Amit and Randhir would be taunting me. That's why I put this question to you. Do you think endosono has any role in portal hypertension management? So let me throw you a bait. What about gastric varices? I mean, if you have done glue, for example, or where do you think it might have a role in portal hypertension?
I think I'll start off by, I think, complimenting your starting with portal hypertension. You're one of the first people who talked about, I think, varices and rectal varices and things like that. And you published very early on this. So regarding portal hypertension, in fact, initially studies came about paraesophageal varices, the perforator veins and all the role in, but then
you must remember that time it was only diagnostics. We didn't have an opportunity of putting in a needle.
Yeah. So now I think there's one area where I was also very skeptic, but I'm now coming to become a believer. This is in patients with large fundal varices. We of course do glue injection, but if there is expertise available, if the patient can afford, I think a better way of dealing with these gastric varices is putting in angioemboli and then glue injection through endoscopic ultrasound done through the esophagus, not to the stomach. It can be very, very safe. The chance of bleed is very low, and you can target those perforator vessels. And I found that when you put a coil and a small amount of glue so that you prevent embolization, it can be quite dramatic. As I said, I became a late believer in this, and now in our unit, I've seen many of these cases treated this way. And I think it's a fairly good way of treating large fundal varices, especially to obliterate them completely.
So I hope Sandeep is living up to his reputation of coming out from PGI, okay?
And regarding,
great, wonderful.
Regarding this mass, pancreatic mass, of course, we all agree with others that I think for malignancy, there's no role, but there's one situation, autoimmune versus, there are some situations where you want to differentiate autoimmune versus pancreatic CA. So if there are certain clinical, biochemical and imaging to suggest autoimmune, then I think it may be worthwhile to do
that.
So can I diagnostic or a biopsy?
Biopsy, FNB. FNB, not FNB.
Okay.
Can I just intervene?
Yeah, Randhir, you had a point. Quick one.
Yeah, you know, one area of malignancy is that hilar cholangiocarcinoma, which is operable, and you want to be certain that there's no lymph node in the vicinity. That's one area before surgery or a liver transplant. You would like to screen for a hilar lymph node and sample it in case you want to operate.
And this point also, this is a good point Randhir made. What I would suggest is that those who are doing US, use a forward viewing US. When you use a forward viewing US, unlike a side viewing or oblique, then hilar region is very well made out. And you can get the hilar pathology very well. So when you're studying the hilar, if you have facilities in department, best is to use a forward viewing US.
Yeah. In your previous talk, you discarded the radial anyway. So I can understand.
No, I'm not. This is not the side viewing also. The forward viewing is separate.
Okay. No
not
problem.
the linear. Not the linear.
I understand. Joking. Amit, you know, for pancreatic disorders, you're a great guy with pancreas. So where exactly now do you use the interventional part in pancreatic disorders? You know, we have heard a little bit about management of pain in pancreatitis and so on and so forth. I mean, can you just elaborate on which are the areas where young people might really like to pick on that?
First of all, I think this is a very rare situation that where we have to resort to interventional EUS for pancreatic disorders, especially chronic pancreatitis. The only few indications which I can think of is where ERCP has failed. There are very tightly impacted stones and you just can't get across through the ampulla of Vater. They could be juxtapapillary stones or in the neck of the pancreas. You can make a puncture through the stomach into the pancreatic duct, do a rendezvous procedure, and that helps you in achieving a proper cannulation. Second is in those patients who have undergone a surgery in the past, like a Whipple's, where they have developed a pancreatico-gastric anastomosis or pancreatico-jejunal anastomotic stricture, and they develop chronic pancreatitis, recurrent pancreatic pain. These are ideal situations where you can approach through US and you can directly drain the pancreatic duct, open up the anastomosis, you can place a stent across it, or even just do a pancreaticogastrostomy. These are the two main areas of pancreatic disorders. Leave alone, of course, obviously the pancreatic cysts, where we nowadays always start do it US guided. We don't do a ERCP guided approach unless we are doing transpapillary. So very rarely, but these are the few indications for pancreatic disorders.
Thank you so much. They're telling me that time is up, but I have to give a little bit of time to Dr. Mahesh and Dr. Adarsh just to complete the second round. Rajesh, I hope you'll bear with me as quickly as possible.
Yeah, I
Mahesh,
think we are only 4 minutes late according to our
Okay.
schedule. And
so
this
that's
is the
not
last
a bad thing because we started at least 6 minutes late, so that's okay. So that means we are before time. So, Mahesh, in your practice in Calcutta, you're the Eastern Star. Where do you use endoscopic ultrasound as an intervention?
I would say, Dr. Gordas Chaudhary, to summarize, we have discussed everything. There are 4 situations where I'm very comfortable using it. Number 1, peripancreatic fluid collections. We have already discussed that. Number 2 would be celiac block. I think this is something which we have not discussed. Celiac block through the EUS, whether you're doing for carcinoma pancreas, carcinoma gallbladder, or for chronic pancreatitis, has completely replaced percutaneous celiac block, which we used to do about 10 or 12 years back. This is number 3 would be a difficult biliary approach, which we already discussed. Where do we place EUS in the algorithm? I think time will tell. Some people will do it before pre-cutting. Somebody would do it after pre-cutting. Somebody would do PTBD as a preferred modality, but there is a place for biliary drainage. And the 4th thing what Nagi talked about is large gastric or resistant gastric varices. I think these are the 4 indications where I think it's well established. There are many more indications which we have been shown today. We have discussed it, but I firmly believe that these 4, there's no doubt about the use of therapeutic use.
Mahesh, let me ask you a question which calls for introspection. All the people in the panel today are people who started off without being endosonographers, to be precise. Like we were all good with endoscopy, therapeutic endoscopy, ERCP, and so on and so forth. Do you feel that we are a little bit of a vintage group who have resisted the use of endoscopic ultrasound interventions which our youngsters have tried to bring forward? Or do you think
I would not use that word that we are vintage. I think we are all mature and wise, and we possibly restrict the younger people to utilize it in a haphazard manner. So I think a check needs to be done, something which can be done in a safer way or a better way. I think we are there to check the younger people. We are not obstructing them. We are checking them to misuse this modality.
Good choice of words. Wonderful. Let me go to Dr. Adarsh Chaudhary, the last panelist today. Adarsh, like with this real amount of enthusiasm of poking needles, into the GI tract and pancreas and all that, do you ever get to see complications of endosono? You probably wouldn't be seeing too many because Rajesh Puri is an excellent endosonographer, But I mean, have you heard of instances where complications do occur?
Mute.
You're probably
muted.
muted, Adarsh. So if you can unmute yourself.
Sorry, I have never had to operate a patient for a complication of EUS. So when we operate, there may be a hematoma or something, but I've never had to operate a patient for a complication of EUS intervention.
So it means it's reasonably safe.
See, it seems so.
It seems so. Great, very mature. May I now request my 2 very eminent chairpersons to give their comments also and share their wisdom? TSC, first you.
You're muted, TSC.
TSC, you're muted. I can see your lips moving. Yeah.
No, this is the first time that you can't hear TSC.
I'm very happy that others telling diplomatically that there is no complications.
Have you seen any?
No. US related complication. Only thing is, if you have a lamb sometime, it's been reported to have a torrential bleeding. So now we started putting the double pigtail. This is one major complication, life-threatening complication. One has to be very careful when you are introducing lambs through US. So that's the only thing I would think of.
So kudos to people like Rajesh Puri and Sandeep. That they have trained the next generation so well that the complication rates are so little. Amazing, very good. So India has a good future ahead. Amrinder Puri, you obviously share a lot of wisdom. Your last words.
Unmute yourself, Dr. Puri. Dr. Puri, unmute yourself, please.
Words of wisdom have no meaning if they're muted.
No, I know that. No, so I have nothing more to say to that. But for Dr. TSC, the bleed with lambs is associated with the lengths of the time that you leave the lambs in. And if you leave it for a longer time, whether you put a DPT or you don't put a DPT, that's not going to help, sir.
It happened to be reported with the lamb, so I'm just spelling that.
So can I just add one word?
Yes, please.
See, I think in my career of last 10 or 12 years of EUS, I have seen one complication, and that was a wrong assessment of the maturity of the peripancreatic fluid collection. I thought it was a mature wall, but then there was a leakage and there was any air. It did not require a surgery, but we had a difficult time. So I think assessing the maturity is very important when you are doing a peripancreatic fluid collection. Though there are reports now that they have done it in the earlier part, even in the second week and third week. But I think in general, we will wait for 4 weeks for the wall to mature.
No, I think this complication thing, GC, we should be careful. We should not give an impression to the younger generation there's no complication. There are complications. I think Adarsh is being diplomatic. We have seen perforations. We have seen problems in terms of what TSA said earlier about lambs putting in. The displacement of hepatojejunostomy stent, very commonly it gets displaced into the peritoneal cavity. The bleeds that can occur at the puncture site, the infections that can occur following trying to drain cysts. So there are, I think we should be very clear. In fact, the average complication rate reported in literature is 20% with therapeutic EUS. And I think we should keep that in mind. Maybe you're some extraordinary areas you're not seeing, but generally it's about 20%. I think that's the message that we should give to.
Yeah, GC,
Thank you very much. Yeah, Amit has a last point. Yeah, Amit.
Even I've seen, we have also seen quite a few complications after interventional EUS. And one of the things is cholecystogastrostomy. Gallbladder drainage can be associated with a perforation because these stents may not be fixed properly. They will just hang into the peritoneum and the patient will need an emergency surgery. Second, of course, we have seen is perforation of the duodenum also with a EUS scope. That is also possible because these complications can occur with interventional EUS. So you have to be very careful.
Very good. So it means if you're not getting enough complications, it means either you're too good or you're not doing enough. So, I mean, both ways we can look at it and decide how to go forward. I think I must thank Dr. Rajesh Puri for the privilege that he has given me to moderate this panel discussion. Rajesh, I think you're one of the great endoscopy ultrasound experts of the country. You are running a wonderful training course, and I think a lot of your students are emerging as great people doing fantastic service, and I wish you all the best. You seem to have lost weight, and I want to congratulate you for a very successful meeting. Thank you very much.
Sir. Thank you, Dr. Gordas Chaudhary, sir, keeping the last session on time, and I am thankful to all the panelists, stalwarts of endoscopy. I think right from the chairperson to the moderator to the panelist, I'm thankful to them, and because of their guidance, we were able to do this conference successfully. And I would like to thank all participants. And we will start our tomorrow session by 9 a.m. with the live demonstration from the Mumbai Ideal Care. And then we have a very good, excellent international speakers. So I request all participants and the faculty, if they got the time, they should please join us. Thank you for the patience hearing.
Thank you, Rajesh.
Thank you. Such a pleasure, all of you. Thank you very much.
Thank you so much, God.